The next topic, actions of estrogen and progesterone. Okay, so estrogen causes upregulation of progesterone receptors. Progesterone causes downregulation of estrogen receptors. Okay, so basically estrogen is helping progesterone and progesterone is decreasing estrogen. Okay, progesterone acts only on estrogen primed endometrium. Even though progesterone needs estrogen because it cannot act if the endometrium is not primed by estrogen, it still downregulates the estrogen receptors. But estrogen, on the other hand, causes upregulation of progesterone receptors. Okay, so yeah, and now the action of estrogen and progesterone on myometrium. Firstly, estrogen increases myometrial contraction, increases the number of cells in myometrium, so the size of the uterus will increase. Progesterone decreases myometrial contraction. It's like relax and just secrete, just maintain yourself, and it helps estrogen in increasing this number of cells in myometrium. So basically both of the estrogen and progesterone are helping in increasing the number of cells in myometrium, but the main effect is due to estrogen. Okay, the number of cells in myometrium is increasing due to estrogen, but progesterone is helping estrogen, but progesterone still causes downregulation of estrogen receptors. The uterine size increases mainly due to estrogen and a little bit due to progesterone. Okay, so on endometrium, estrogen causes proliferation of endometrial glands. We all know that. Progesterone causes secretory changes. It's an anti-proliferative action. So that is why we say that progesterone causes downregulation of estrogen receptors. Now, what are the secretory changes? It maintains the endometrium. The glycogen and lipids secretion provides nutrition to the fertilized ovum and it causes vasodilation. So these are the secretory changes. Now, if you look at this, the first image, you see there are long tubular glands. So this image depicts that the endometrium is proliferated. And who is causing proliferation? Estrogen. So this is the image of proliferated endometrium. Now, in the early secretory endometrium, we have vacuole, subnuclear vacuolation. So if there is we know it's an early secretory endometrium. Late, we have corkscrew or sawtooth glands, which are tortuous glands. Now, vacuoles are big and heavy, tortuous, so it looks like a corkscrew or sawtooth gland. So it's a late secretory endometrium. Then we have proliferative endometrium, we have three layers: trilaminar, which is stratum or zona. I'll just say one of them. Okay, stratum compacta, stratum spongiosum, stratum basalis. Compactum is outermost, spongiosum is middle one, and basal is the deepest layer. Okay. Now, stratum basalis does not shed off during menses because it is regenerating late. So what does not shed off during menses? It is stratum basalis. Now, secretory endometrium is hyperechoic due to acoustic enhancement, due to vacuoles. These are like these vacuoles have fluid filled in them, so it is hyperechoic. More white endometrium you will see. And on cervix, the action of first I'll divide. Endometrium has three layers: the proliferative phase or the estrogenic phase. It is stratum, zona, compactum, stratum, zona, spongiosum, and then basalis. Compactum, spongiosum, and basalis. Basal is the innermost or the deepest layer, and it does not shed off during menses. Secretory endometrium is more hyperechoic due to the acoustic enhancement. Now, action on cervix. Estrogen causes cervical mucus to become thin, watery, profuse, or alkaline. It can cause it to become elastic, which can be stretched up to 10 centimeter and does not break because it is elastic. Elastic does not break even how much you stretch. This is known as spin-Barrett phenomenon. Spin-Barrett phenomenon is when you can stretch the cervical mucus up to 10 centimeter and it doesn't break. So this is known as spin-Barrett. This is the action of estrogen and alkaline. Estrogen makes it alkaline. Now, cervical mucus is good for sperm penetration. Good for sperm penetration is estrogenic. That is when the sperm enters and then ovulation can happen. So before ovulation is the estrogenic phase. So that's the best period for sperm penetration. Now, progesterone causes the cervical mucus to become thick, scanty, non-elastic. It breaks on stretching. This is known as stack phenomenon. It's stacky. It breaks on stretching. So estrogen shows coarse furring or arborizing due to NaCl. And progesterone causes no furning or no arborizing. So for estrogen, what we saw, it was copious, thin, watery, profuse, alkaline, spin bucket phenomenon, can be stretched up to 10 centimeter because it's elastic. It's good for sperm penetration, and it shows coarse furning due to NaCl. Progesterone shows no furning, it's thick, it's scanty, it breaks, which is a tack phenomenon. Cervical mucus impermeable for microorganism is progesteronic phase, obviously. Okay. On vagina, so the epithelium, first of all, the epithelium of vagina is stratified squamous non-keratinized epithelium. It's a non-keratinized epithelium. It's not keratinized. It is non-keratinized. Okay. Now we have three types of cells in vagina: basal and parabasal cells. In between we have intermediate cell, and then we have superficial or cornified or eosinophilic. So basal layer was also in the endometrium, right? Basal layer was also in the endometrium, which was not shedding, and here in vagina we have basal cell, which is again the innermost. So between we have basophilic, and the outermost we have superficial or cornified or eosinophilic cell. Now let's talk about their predominance, where and when they are found. So in normal condition, when there is no hormonal predominance, and when there is no hormonal predominance, before puberty and after menopause. These are the two situations where you will have no hormonal predominance. It's not like you have estrogen more or progesterone more. Before this puberty and after menopause. Before menarche, after menopause. So at that time we'll find basal and parabasal cells. Now when we have abundant progesterone, which will happen during secretory phase and during pregnancy, because pregnancy, if you remember, it's a progestational hormone. So during this we'll have basophilic. We'll have basophilic cells more. Superficial cornified or eosinophilic cells will be more when you have abundant estrogen, which will be in case of proliferative phase. So if you see that eosinophilic cell is present, okay, on a histopath, you see the eosinophilic cell is still present, it definitely means that ovulation has not occurred, because if ovulation would have occurred, estrogen would have decreased and progesterone would have been predominant, as it is seen in secretory phase. So you'll see basal and parabasal cells. Not basal and parabasal cells, basophilic cells. Don't get confused like me. Basal and parabasal was in no hormone predominance, okay? So if eosinophilic cell is present, it means ovulation has not occurred. It's still in the proliferative or estrogenic phase. And if you see that intermediate cell is present, the basophilic cell is still present, means ovulation has occurred. Now talking about the maturation index. So we calculate the ratio based on 100 cells, okay? Like, so there are a total of 100 cells. Now in first half, estrogenic. So what will be predominant? Think, what will be predominant? Eosinophilic cell or cornified cells, right? Or superficial cells. So what you will see, that you will see 0, 40, 60. So this is the order we write: basal, parabasal, intermediate, superficial. So why 0? Because you are neither in pre-puberty or neither in postmenopause, so that is definitely 0. 40 because you still have some amount of this basophilic cell, but you have more superficial cornified or eosinophilic cell in the first half. So 0, 40, 60. Second half you have more progesteronic cells, which are basophilic cells. So 0, 70, 30. In pregnancy, what is more? Basophilic cell is more, but very, very high. So 0, 95, 5. And before puberty, it is 100, 0, 0. Cool. First half 0, 40, 60. Second half 0, 70, 30. Pregnancy 0, 95, 5. And then pre-puberty, or you can say post-menopause, it is 100, 0, 0. After ovulation, maturation index shifts from right to left. Right to left, because right is what? This is the rightmost, right? Superficial. So after ovulation, now this is increasing. The basophilic cell is increasing, so shift to right to left. So in case of after ovulation, okay. Cornification or index or eosinophilic index is percentage of cornified cells, okay. That's quantification index. Now it is maximum in proliferative phase, that also we know. Samples for hormonal studies is taken from lateral vaginal wall. Lateral vaginal wall. Samples for hormonal studies is taken from lateral vaginal wall. Now action on breast. So estrogen causes ductal growth and fat deposition. Estrogen causes ductal growth and fat deposition. Progesterone causes glandular development. How do we remember this? If you remember, vesicles, glands, all of this secretory thing was the function of progesterone. So glandular development is progesterone, ductal growth, the number of cells increasing, duct is growing, fat is depositing, all of these are function of estrogen. Okay, we already said that aromatization occurs in women who are more obese and they have more estrogen. So fat deposition is clear. You can get confused between ductal and glandular. So glands secrete this, vesicles, all of these are for progesterone, and duct is for estrogen. Now breast size increases due to both estrogen and progesterone, because overall they combine together to increase the breast size. Now on bone, estrogen causes mineralization. Why calcium? It causes closure of epiphyses and it decreases serum calcium. So you will see that in precocious puberty the women will be short because the estrogen decreases the calcium in the serum, right? It takes the calcium from the serum and it deposits in the bone. So the serum calcium will be short and will decrease. Also, estrogen causes closure of epiphyses, so there will be no growth, right? So yeah, mainly due to that that estrogen causes the closure of epiphyses. So if there is a precocious puberty, you will be short statured. Okay. Progesterone has some osteoblastic activity. Estrogen has the main function, which is mineralization and closure of epiphyses. Which leads to, in case of precocious puberty, for the women to be short in stature. Okay. On fallopian tubes, estrogen increases tubal peristalsis. Again, the tube function, duct function, all of these are for estrogen only. So tubal peristalsis increased by estrogen, decrease. Also, if you know that estrogen causes contraction and all of that, in case of myometrium as well, and progesterone was the one who was relaxing it. So progesterone is a smooth muscle relaxant, so it will cause relaxation, it will decrease tubal peristalsis. Coagulation, estrogen is a procoagulation because it increases clotting factor synthesis. So all clotting factor except 11 and 13. All clotting factor except 11 and 13 are increased by estrogen. Progesterone has no effect on coagulation. So we'll next topic in the next video.